remarks. So this is a screenshot I took yesterday from the WHO, indicating perhaps the extent of what we face and what we live with at the moment. With currently almost 6.5 million confirmed cases around the world of COVID and approaching 400,000 deaths, with approximately 100,000 new cases almost every day. If I go to what has occupied my time, and I'm sure many and most of your time, it's this, that almost on a minute-by-minute basis, there is new information that is coming to my phone and my screen on COVID. And just as a PubMed search I did very quickly yesterday, showing that in the last 6 months now, there have been almost 14,000 publications. But here in my world, and your world probably, is the tricky part. If I put the word sport or athlete in, I get precisely 11 publications. I'm aware that there's a lot going on because almost also regularly, and I'm sure many of you, I get asked to review another contribution from somewhere on this topic. But we do not have much science. That is what this slide says. So I've been working with a IOC consensus group that I'm chairing, which is on acute respiratory illness in the athlete. It's a group of people that we brought together middle of last year under the auspices of the IOC, and we started working on the topic of acute respiratory illness. And of course, since January, February this year, the work of this particular group has been thrown upside down because the single most important topic worldwide at the moment has fallen right into the work of this group. So what I want to share with you first are just a summary, perhaps, of some of the clinical challenges that we face as sport and exercise medicine physicians. And there are a summary of perhaps 14. I'm sure there are more, but this is what the subgroup that we've now formed on COVID and the athlete within the IOC consensus group on acute respiratory illness. This is the list that we came up with. We are faced with challenges around epidemiology and risk factors of COVID for athletes. We're trying to understand, and we have to become almost respiratory, cardiac, neurological, renal, gastrointestinal, and dermatological experts, because the pathophysiology and the pathology of COVID is vast. There are questions about the immune system. There's a wide spectrum of clinical presentation of the disease. The aspects of management, and of course, a big topic, particularly I would say the last 4 weeks or so, has been the risk of transmission as we return back to sport. Coupled with that are prevention strategies that we have to come up with, guidelines on screening, and then the one that I'm going to tackle today for almost the remainder of the talk is about returning to sport or returning to play. Understanding that there are potential implications on exercise performance and adaptation to training, potential risk of medical complications in the future. Some aspects that we have to consider would be monitoring of athletes, and probably one of the most important ones would be the mental health issues that all of us face and all our athletes face. So of course it's impossible for me to tackle all of these today, but I wanted to indicate that maybe Richard will speak a little bit later about a resource that the IOC is busy building that will capture information as it comes about in these 14 areas. What I want to talk to you about is what occupies a fair amount of my time, which is a phone call, an email, or a WhatsApp or a text message about athletes that I manage. And so I am involved with athlete management on a day-to-day basis where I am in Pretoria at our center. And currently there's a lot of discussion about what happens to your team or your squad in the current pandemic. Around the world, restrictions, known as kind of lockdowns, are lifting. And more teams and individuals prepare to go back to training and competition. And so the issue is, if I had to look at this particular athlete, just one of the athletes in the squad, what are the considerations that I need to be aware of every single day? This would be for a team setting, but it could also be your own personal exercise habits, or perhaps that you're looking after individual athletes that are not necessarily in a team setting. So the first question is, how do we approach this? And I would start off with the first maybe practical point. I think it's very important to know the daily clinical status of your athlete. Sorry, that shouldn't be to athlete, but it's of your athlete. So what are the kind of things that are probably worthwhile establishing and knowing about every athlete every day? Well, firstly, the general health status of your athlete. And we've all been involved in periodic health exams on an annual basis for our elite athletes. And it would be worth going back to that list and just consider the comorbidities, which may or may not be controlled. And remember that these are medical issues that can be in younger, healthy athletes, including respiratory illness such as asthma, or perhaps even diabetes. The second most important point to know about your athlete is, where are they at the moment in their so-called COVID status? And here are the things to know every day. Does your athlete have any symptoms? And I'll give you in the next slide our symptom checklist that we've compiled, that we are collecting on athletes. Does your athlete have a fever? And it's possibly worthwhile having that tested every day, or measured every day. Has a diagnostic test for COVID been done, either because your professional sport requires it, or because symptoms have been present either recently or currently? And then perhaps a kind of an assessment of what is the risk of COVID-19 in that athlete in the last 14 days. Maybe some issues around recent contacts, travel, what is the current community risk within your country or your region, and to what extent does the athlete or the group of athletes that you are looking after adhere to the public health guidelines. And then finally, what is the plan for the day, the training or competition plan for the day? So I would suggest that the first practical thing is to know these aspects of the history of the athlete and check on this every single day. This is probably too small for you to read, but essentially it comes down to the following. One of my PhD students is conducting a research project, and we've really adapted a daily symptom checklist for acute respiratory illness. We've divided them on the left-hand side of the slide into three big groups: the so-called nose, throat symptoms, and maybe then regional symptoms, chest, head, and neck symptoms, and then systemic symptoms. And it's worthwhile finding out from every athlete whether they have any of these symptoms. And we also adopt a severity score from 1 to 7 based on the Wisconsin criteria, which are international criteria for respiratory tract illness. So identify the presence of a symptom and perhaps the severity of that symptom, and know that for all your athletes. It's probably worthwhile having that on some electronic platform if you can make it happen. So I want to go through using this information through a practical clinical approach to these spectrum. So I divide my athletes into three groups. Firstly is a group of asymptomatic athletes. They've checked either none or maybe one or two in a very mild form of those symptom checklist. And there are three subgroups within that: those that have never been tested or not tested for COVID. And as I've indicated, in some sports, it requires that a COVID test being done before they return. And that test is then either negative or positive. The second group would be those that tick symptoms. They are currently symptomatic, and they have either fever or some of the other symptoms of an acute respiratory illness. And once again, those could either be then not tested, or they could have a COVID test which is either positive or negative. That not testing is dependent on the local requirements and the demand for testing. And so for young athletes, for example, perhaps not elite athletes, this may not be routine. The last group of people, which is an emerging group, and these are athletes that were symptomatic and are now declared so-called recovered from their recent acute respiratory tract illness. And again, they may or may not have been tested for COVID, and the test may or may not have been positive. If it was very suspicious of COVID, they should have probably been tested, but in some countries, it may not be possible due to, again, the restrictions. So let me go through each of these groups very briefly. Just some thoughts about what is the likely diagnosis here, what are the next steps, and what is the advice on training. So here's the asymptomatic 1A group. Asymptomatic, they've not been tested. Basically, they are likely, very likely, to not have a current acute respiratory illness. But there are two caveats. They may have had a past asymptomatic COVID infection, probably very unlikely, or they could be currently asymptomatic, prodromal if you like, with either a COVID infection or another pathogen. So what are the next steps? Well, in the current pandemic, one will almost have to say that you have to monitor your athletes daily, even if they're asymptomatic and not tested. It's also good to apply public health guidelines. And again, if the professional body that you're working with requires it, it may be that there would be a role for antibody testing. That's also controversial. I'm not going to go into that too much in terms of the types of testing. But essentially, this athlete, bearing in mind that you monitor and you apply guidelines, can continue to train. Asymptomatic group 2 had a test done for COVID, maybe as part of screening, it's negative. Again, no current respiratory illness is very likely, but they could have had a past asymptomatic COVID infection and therefore be tested negative. It's very unlikely. Or they could have a false negative test and they could have had a COVID infection. Again, perhaps very unlikely. Essentially, this athlete is very similar to the previous group and can continue to train. What about the next one? Asymptomatic, a screening test was done and they're positive. Well, the diagnosis here would be a current or very recent mild COVID infection because they are asymptomatic. That's probably very likely. Or they could have already recovered from a recent infection and therefore still be positive, a false positive test if you like. Again, perhaps that is quite unlikely. What are the next steps here? Well, this athlete has to be assumed that they are COVID positive. That requires a full clinical assessment. Depending on the timing of the test, you need to probably apply self-isolation, monitor for any symptoms because they may be early and still develop symptoms, apply normal public health guidelines, and you could possibly consider repeat COVID test after about a week or so. Training in this case needs to be delayed. And after 7 to 10 days of being asymptomatic from the test date, you can apply, and I'll come back to that towards the end, the return to play algorithm for these patients. What about the second group? The second group is a currently symptomatic group. And again, they could be tested or not tested. I'm going to go through this quite quickly because the current symptomatic group should not train. So the entire flow of the process is that they should not train. If they've not been tested, it is a possible COVID infection because of the current pandemic or a non-COVID infection. So they should be seen because they're sick. And if you can, depending on your ability to do that, resources, to do a COVID test and check. If you can add a respiratory panel, if you have that, that's a good idea because you can then identify if it's a pathogen that's not COVID. Essentially, this group should not train, as I've indicated. And if they're a non-COVID infection, you could probably apply the return to play algorithm a little bit earlier. But if it's a COVID infection, the current guidelines would state that you need to wait a week or maybe even 10 days after the onset of the symptoms, because of the prolonged symptoms in COVID. If they're COVID positive, that makes it easier, not for the patient, but from a diagnosis. This is very likely to be a COVID infection, needs a full clinical assessment, monitoring for new and progressive symptoms, self-isolation, and definitely no training until at least 7 to 10 days after the onset of symptoms. If it's an acute infection, and they are COVID negative, it's likely to be another pathogen. We tend to forget in this time that there are many other pathogens that could give rise to acute respiratory illness. But the caveat is it could be a false negative COVID test. What are the next steps? They're sick, so they need a clinical assessment and the severity of the disease. If clinically it is very suspicious of the spectrum of COVID symptoms, you may want to consider repeating the COVID test, but you need to treat, monitor, self-isolate, and public guidelines. And because they're sick, no training, and if it's a non-COVID infection confirmed, you may apply the return to play algorithm a little bit earlier. Lastly, the recovered group, and I'll spend a little bit of more time, towards the end of the talk in a few minutes on the actual algorithm we use. But the first group here would be recovered with no COVID test. So here you don't know whether they had COVID or another pathogen. But given the current recent pandemic and maybe their situation in terms of risk, you have to assume that maybe this is COVID. So if it's clinically very suspicious, you could consider the COVID PCR test. But if it's too late, then you may have a negative test, let's say after 14 days, some cases a bit longer. In that case, you could consider the antibody test with its controversies in terms of the validity and so forth. Here, the advice on training is to delay it until you've done your return to play algorithm. What about the recovered infective illness and a positive test? Well, this is clearly a recent COVID infection, possibly a false positive, but that's unlikely. Then the next steps is to consider a retest to confirm that your athlete is negative. And many sports would require that, particularly the contact sports, to make sure that the athlete is not shedding virus. And again, delay the training. In the case of COVID, probably at least 7 days after no symptoms. Finally, in this entire spectrum of 9 groups of athletes is the recovered athlete with a negative COVID test, likely to then be another pathogen, could be a false negative, but very unlikely. And the next steps that if you are really very suspicious of a COVID infection, you may want to consider a retest. If it's early, a PCR test. If it's late, an antibody test. And again, here you need to delay the training, and depending on if you're suspecting COVID, you may want to delay that return to play for at least 7 days. So I want to tackle, just in the last few minutes, this thorny issue of the return to play algorithm. And a few general remarks to start off with. Well, before COVID-19, we did not really have any good evidence-based guidelines to start off with. The neck check, we know, was not well researched and has recently been challenged by many people. However, with COVID, we have even less data. In fact, we have none. And there are a number of return to play protocols that were recently published, and I'll just refer to them in the next 2 slides. And there are probably a few more in various stages of reviews in journals at the moment. But we all need to understand that the current protocols are really expert opinions at best, including, in fact, what I'm going to share is my second last slide today. Not that I'm an expert at all on this necessarily. So I'm going to leave these, I'm not going to discuss these, but there are really good protocols put together by some fantastic work and colleagues of mine from Germany and from the US in a BJSM blog, and more recently a BJSM tutorial, some work by Keith Stokes and his group, and then finally a very recent couple of maybe even days ago, a protocol from the European cardiologists. And what I'd like to do is not go through these. They are very consistent, certainly in the cardiological area, and I will mention that in my suggestions. But I want to point out some limitations. I've already indicated that there's no data, no science. The problem also, in my opinion, is that they're very specific to COVID-19 and do not really take into account all the other potential pathogens that can either coexist as an infection or be the cause of the infection. The other approach here is that the guidelines are very disease or organ-centered, mostly cardiological, maybe recently more pulmonary as well, and not patient or athlete-centered. And so I want to just point out that we have to be aware of being reductionist and foster a fragmented approach to this. The data for most also, these guidelines, are based on populations with COVID that are not athletes. They're often older individuals admitted to hospital. And we know that 80% of high-level athletes are younger and probably will have mild to moderate disease. They almost certainly will have mild to moderate disease. So what is the dilemma here? The dilemma is that this is just a slide of a running athlete showing various organ systems and all the responses that happen in the physiology when you start to exercise. And I just want to put this slide up, exact same slide, taking into account the multi-organ involvement with COVID. Every single one of the organs in the previous slide, in one way or another, or could be affected by COVID. And I'm not going to go through this. This is a very useful reference in the International Journal of Antimicrobial Agents in a couple of weeks ago, April, for you to look at. So what are the few important points? Well, in my opinion, we have to consider other pathogens. As I said, it's likely to be COVID, but it may be another one. Moderate to severe illness can also occur with other pathogens. Adenovirus is one, influenza is another. So the slide that I just showed you before does not only apply to COVID. The other point is multi-organ involvement, as the slide I showed you, is not only cardiac and pulmonary. There are many other organ systems, as I showed you on the slide. The other thing from guidelines that I find perhaps missing is that the objective is to get the athlete back to safe training. So for me, the final test is to actually observe and document what happens during exercise. And the other last point is that progressive exercise training, as the training is increased, training load is increased, this may unmask subtle underlying organ injury or damage which may not be present at rest. So once cleared from an RTP protocol may not mean that normal adaptation to training load will occur. And just another point to consider. So I'd like to finish off with a 5-step approach that hopefully will take some of these limitations into account. And again, this is just an opinion, maybe not even an expert opinion. The first is very simple: to take a really good history and assess the severity of the infection, conduct a comprehensive clinical assessment, which may be different from what we did a few months ago, where the focus is to identify not only residual infection, but to focus on multi-organ injury and to confirm the severity of the infection. There would be a step, of course, in this process of laboratory and special investigations to exclude, once again, suspected multi-organ system involvement. What I would like to suggest is that the final test is a graded submaximal or even maximal exercise test, designed to unmask these residual symptoms of multi-organ involvement. And then when implementing a graded return to play, the plea for ongoing monitoring. So let me put this into an algorithm for you and start off by step 1, a good history. And the history should really be able to distinguish between a very mild acute respiratory illness or even an asymptomatic illness. Probably 80 or even 90% of athletes will fall into that left box. But the history should also be able to distinguish between those that have a suspected moderate or severe illness. The next step is to perform a comprehensive clinical assessment. And I put there 2 boxes because the one on the right-hand side would probably, in modern day medicine, be accompanied by a test to determine by point of care, the actual pathology, the pathogen. And that can help us a lot in the next step. If we go the green route, this is somebody after a mild or suspected mild or even asymptomatic infection, do a comprehensive assessment. They are asymptomatic, maybe with some mild residual localized symptoms, but no infection, no organ injury, no pathogen that we know causes severe illness, and normal lab tests. I would then suggest a submaximal exercise test, which then could either result in normal symptoms, no abnormal symptoms, and a normal response, and then implement the return to play protocol. The same pathway would be for a mild or a moderate infection that is accompanied by no symptoms and those other criteria in the green box. What about a moderate infection even a mild infection with residual symptoms and signs that's suggestive of an infection, or where there's any suspicion of multi-organ injury. In this case, we would suggest a laboratory special investigation protocol that would be focused on the suspected organ system involvement: cardiac, pulmonary, vascular, neurological, muscle, renal, etc. Many of my colleagues, and I agree, suggest that for any severe infection, this should be standard to have the laboratory investigations done. And if those are abnormal, then it's clearly no return to play, and manage the conditions and reassess. The last box is the bottom one in red, which indicates that if the symptom-limited maximal exercise test results in abnormal symptoms or an abnormal response to exercise, I would suggest there's no exercise and you need to go back and manage and reassess. So in summary, just a whirlwind through a clinical approach to your athlete today. First point, we live in challenging times with an ever-changing landscape. What we say today will likely change tomorrow, and probably on Monday morning, this talk is outdated. Your first practical point is, I think, know the health status, COVID status of your athlete, everyone and every day. Have an approach to each of the 9 possible scenarios when it comes to symptoms and testing. Have an approach to the advice on return to training. And my few bullet points there: consider the severity, know the pathogen, be aware of multi-organ involvement, have a multidisciplinary team approach to it, adopt the principles of shared decision-making. I would value the graded exercise test response. Be aware of ongoing monitoring. And the last point is we really need research and lots of data. So I'd like to end there and thank you for your time.